Probably a good idea, but you're going to have. I wanted to introduce Dr. Radhika Shah, the newest member of our faculty. She joined a week ago, and Dr. Shah did her medical school from Rutgers, her residency in internal medicine from Yale University, and has completed a pulmonary and critical care fellowship at the University of Maryland and joined our faculty and is extremely interested in resident education and in fact has quite a bit of protected time to indulge her interests in that field. So please get to, after she's finished her talk, do stop by and say hi. And if you're interested in pulmonary and critical care or even anything else in terms of research, I think you'll find her a great resource. So thank you for doing this talk, Radhika, at short notice. I leave you to it.
Thank you, Dr. Sethi, for the warm welcome. So I apologize for standing behind the podium the entire time. I guess we're going to record this and broadcast this on YouTube, so you guys can watch this multiple times if you want to. So we're going to talk about sleep and fatigue in training programs. So hopefully some of this stuff is going to be maybe a little bit redundant for you guys. You know all this stuff a little bit, but I think that overall that a lecture like this is important to do once in a while to kind of force trainees and all of you guys to think about what you're doing in your daily lives in terms of residency and your time at home and how to develop strategies for being able to function better in the hospital and have better quality time at home as well. And so I think it just forces you to take an hour and think about, is there a couple of small changes that I can make in what I'm doing at home to just make life a little bit better? So that's why I think this is important, even though I know some of this stuff you guys know well already. So specifically, our learning objectives today are going to be to list factors that put you at risk for sleepiness and fatigue, to describe the impact of sleep loss on residents' personal and professional lives and on resident and patient safety, recognize signs of sleepiness and fatigue in yourself and others, challenge common misconceptions among physicians about sleep and sleep loss, and adapt alertness management tools and strategies for yourself and your program. So why is this topic important? So residents have the equivalent amount of sleepiness as certain sleep disorders when you actually look at the numbers. So if you look at this chart, on the y-axis is Epworth score. Epworth score is a survey tool used by a lot of sleep physicians and primary care as well to determine how sleepy a subject is. So for instance, it'll have questions like, how likely are you to fall asleep when you're at a red light while you're driving or while you're watching TV? And the score is out of a maximum score of 24, and being under a score of 11 is considered normal. So if you look, residents fall somewhere between having sleep apnea and narcolepsy. So it's sort of an important topic to talk about because it puts them in the category of some serious sleep disorders. So why is the problem of sleepiness and fatigue in residency underestimated? So culture of medicine is sort of the short answer for this. Throughout your training, it's often thought of that sleep is optional, that if you're tired or not able to do your job because you're tired, you're not dedicated, you're not as motivated as other residents in your specialty, and that if you get less sleep that you're a more dedicated doctor. So it's a perception that sleep is not important or not a priority for medical trainees. The other perception is that if you reduce work hours, you're going to compromise patient care through basically increasing the amount of handoffs during your training or during your shifts and reducing educational opportunities, basically not being able to see a patient from kind of admission to throughout their initial admission, basically, timeline. So this is kind of the reason why it's been so difficult to make this a priority in training programs. So what causes sleepiness? Again, this is sort of common sense, but it's something to kind of focus and break it down and think about while we're all here talking about this subject. So sleepiness is driven by two things. It's driven by homeostatic drive for sleepiness. So that's basically as you're awake, you develop a sleep load. So the longer you're awake, the sleepier you'll be. And then the other piece of that is circadian rhythm. So those are the two things that are going to cause sleepiness. If you're in the wrong part of your circadian rhythm and if you have a high sleep load. So we're going to talk a little bit about some myths in training programs regarding sleepiness. So one of them is it's the really boring noon conferences that put me to sleep. Hopefully not this one. But so yes, environmental factors such as dark rooms, having sort of a monotonous speaker or et cetera, room temperature may help unmask sleepiness, but that's not the real cause of sleepiness. So the cause of sleepiness is going to be those two things that I just said. So homeostatic drive for sleepiness, so increasing sleep load, and circadian rhythm. So just to break this down a little bit further, so specifically in residency, what's going to cause excessive daytime sleepiness? So if we talk about decreased insufficient sleep, or basically increasing the amount of sleep load, you can break that down into two basic parts. So insufficient sleep in general. So if you're sleeping on call, if you're you have a night shift, etc., and you have no sleep, you're going to have excessive daytime sleepiness. Also, if you're on call and then don't sleep enough after you're on call, that's called inadequate recovery sleep, which we'll talk about a little bit more later, but that can also cause excessive daytime sleepiness. And then fragmented sleep. So if you're on call and you have a lot of phone calls, pagers, things like that, that's also going to cause excessive daytime sleepiness. And then the second thing that I did talk about was circadian rhythm. So you're going to have sleepiness while you're awake if you're on the wrong part of your circadian cycle. So if you're going to be awake during nights, that will cause excessive sleepiness. And then, residents and trainees are, just like any other person, can be at risk for sleep disorders. So things to think about are sleep apnea, narcolepsy could be real problems if there is excessive daytime sleepiness. Okay, so another myth regarding sleep and training. So like a lot of residents, I only need 5 hours of sleep, so none of this applies to us. So I'll talk about this again, but sleep need and how much sleep that any individual needs is genetically predetermined. So we all know those people who can sleep 4 hours and are great. That's their natural need for sleep, and they can work all day and to be totally fine, and that's what they get every day, and they feel well rested. But that's kind of few and far between. Most adults need 6 to 10 hours of sleep, and that is genetically predetermined. You cannot change that. You can't get used to it. That's what you need. And as you spend night after night with less sleep than you actually need, you develop a sleep debt. So after your first night of not getting sleep, your attention and working memory functionality decreases by 25%. After your second night, it decreases by 40%. So it's a real issue if you're not getting the amount of sleep that you're genetically predetermined to need to function properly. So how do we reduce the impact of sleep loss? So one strategy is to avoid starting out with a sleep deficit. So they've done studies, survey studies with residents on how much sleep they're getting on certain rotations. So in this study, they found that residents who were on light rotations or no call rotations were still getting on average 6.3 hours of sleep. So, a strategy for somebody who's, say, pre-call, if you're about to be on call for 24 hours, et cetera, don't start out sleeping the night before 6 hours, right? So the recommendation is to sleep 7 to 9 hours before you're going to have a sleepless night, right? Okay, another myth for trainees. I've learned not to sleep as much, not to need as much sleep during my residency. So this is, again, a repetitive from what I just said. So sleep is genetically predetermined and can't be changed, and you can't train yourself to need less sleep. You can, on a short-term basis, sort of improve your performance on tasks with some effort, but really the key is consistency of performance, and that doesn't occur unless you have adequate sleep. Okay. All right, so let's just talk a little bit about the structure of sleep. So to orient everybody, these are two hypnograms, and the top one is representative of normal sleep, and the bottom hypnogram is representative of on-call sleep. So let's just look at the normal sleep one for now. You'll see on the x-axis is the hours of sleep during the night, and the y-axis is stages of sleep. So stages 1 and 2 of sleep are considered lighter sleep, and stages 3 and 4 are considered deep sleep. And then REM is characterized by rapid eye movements and lack of muscle tone. So REM and stage 3 and 4 sleep are considered restorative sleep. So when you go into those sleep states, it's considered, that's when you feel better when you wake up in the morning. So the beginning of the night, you tend to have more stage 3 and 4 sleep, and then later on in the night, you'll see longer periods spent in REM. So that's a normal night of sleep. If you go down and look at the on-call sleep hypnogram, you'll see that there's much less stage 3 and 4 sleep at the beginning of the night. There's actually no stage 4 sleep in the beginning of the night there. And you look at the REM sleep up here, and it's very fragmented, and it's definitely not for as long periods of time as the normal sleep is. So you can see how on-call sleep can be very disruptive to having a restorative effect in the morning. Okay, so let's talk a little bit about the circadian clock. So the circadian clock is a little bit longer than 24 hours, actually. So what people suggest when you're doing shift work, and I don't know how the emergency residency program is constructed here, but for people who do kind of like those 8-hour shifts where there's a day shift, evening shift, and night shift, it's recommended that you adapt to shifts in a forward fashion. So start off with day shifts, then switch to evening shifts, then switch to night shifts, because it's easier to stay awake longer than to fall asleep faster. So that's like the analogy for that would be, it's like easier for us to travel to the West Coast versus coming back from the West Coast to the East Coast, because it's easier to stay up later at night. So that's sort of the analogy for that. Okay, so this is a graphic representation of what I've been talking about in terms of the sleep load and developing a sleep load the longer you stay awake, and your circadian drive. So basically, if you look at the yellow arrows, this is your propensity to stay awake through your circadian drive, and you'll see that it goes up throughout the day while you're awake. And then when you're asleep, that you have less circadian drive to stay awake. Versus, so this is the reason why even if you do sleep a lot during the day, say before a night shift, you're still going to feel tired at 3 a.m. because of your circadian rhythm. And then at the top, you'll see sleep drive, which is in the green arrows. And what you'll see is that as you stay awake for longer, your sleep load increases and then you fall asleep and your sleep load decreases. Okay. So that's sort of the graphic representation of what I've been talking about. Okay, so what are the consequences of sleep deprivation? Why are we talking about this so much? So specifically for residency, there can be a lot of consequences for patient care and for personal life as well. So for instance, so driving safety is a big one, and we'll kind of talk about each of these topics a little bit more in detail. Patient care and professionalism, your education, your own health and well-being, family relationships, mood and performance, and your workplace environment. So what's the impact of sleep deprivation on professionalism? So they've had a number of focus groups with interns and residents regarding their feelings on sleep deprivation and their perception of their professional attitude towards patients. And this is a quote from one of those focus groups. So, your own patients have become the enemy because they are the one thing that stands between you and a few hours of sleep. So there's a lot of like disillusionment, a lot of sort of looking at patients as not as people anymore when there's issues with fatigue. So this is another kind of survey study that was done with interns, and basically what they did was they surveyed a training program and divided up residents who slept less than 5 hours a night and residents who slept more than 5 hours a night, and determined how much more likely they were to report certain significant events. So, and they found that all of these things were a higher likelihood of happening if you had less than 5 hours of sleep per night. So, involvement in a malpractice suit, use of medications to stay awake, substance abuse, conflicts with other residents, conflicts with nursing staff, medical errors, etc. So these were all resident reported. It wasn't directly observed, but this was from survey data. So this same survey, what they did was they divided it up, kind of like did a dose response curve, and basically divided up how many hours of sleep people got and the resident ratings for certain things. So I just like to focus on 2 lines there. If you look at the green line, you'll see that learning satisfaction increased with the number of hours, with an increased number of hours of sleep. And if you look at the yellow line, the stress rating went down with the number of hours of sleep attained. So there was a significant impact with increased amounts of sleep. All right, so this is another kind of effect of fatigue and resident performance. So in this meta-analysis of 20 studies involving residents from different specialties, they basically looked at what the neurocognitive effects were for sleep deprivation, and found that in a 24-hour period of sleep deprivation, there was a significant decline in vigilance, memory, cognitive performance, and clinical performance. And this is that same survey study that we were looking at before regarding hours of sleep and your likelihood of reporting errors or adverse events. And if you look at the yellow lines, the yellow bars, you'll see that there was a that the number of errors reported decreased with the increased amount of hours that a resident slept, as well, and the same kind of decrease in the amount of adverse events as well. And again, this is resident reported. So then this study, so I apologize, a lot of this is old data, and they do need a lot more newer data, especially with the new resident duty hours and things like that. But this is from 1971, and basically what they did was they looked at interns who were post-call versus supposedly rested, and had them do a sustained ECG attention task where they had to detect cardiac arrhythmias and like a telemetry basically. And so they found that residents who were sleep deprived were more likely to make errors on that compared to the well-rested. Now it's kind of interesting to note that the well-rested residents still made significant amount of errors, and so they contribute that to potentially chronic sleep deprivation. So even though they were well-rested that night, they might have been chronically sleep deprived. Okay, so a couple of quick things on other specialties. A lot of this stuff comes from internal medicine, but then there's other specific data in other specialties. So for surgery, for simulations, for simulated laparoscopy, they did a couple of studies where they looked at the amount of errors and time required to perform those tasks, and found that there was 20% more errors and 14% more time required to perform those tasks when a resident was post-call. In pediatrics, they did something similar with intra-arterial line placement, and found that there was an increased amount of time required to place that in a sleep-deprived resident. In emergency medicine, they found a reduction in the comprehensiveness of history and physical exam in second-year residents. and when they were sleep deprived. And in family medicine, they found a decrease in training exam scores when they were sleep deprived as well. So this is all, simulations, this is exams. So where does this kind of correlate in terms of clinical care and patient care, right? So this is one study that was performed sort of in the real clinical environment rather than in a kind of simulated environment. Basically what they did was they randomized interns to a traditional Q3 24-hour shift schedule versus a 16-hour maximum shift schedule. And they had them wear ambulatory EEG monitoring during their day, and basically looked at, compared the amount of attentional failures that they had during their shift at night. And they found that in the 24-hour group, that there was a significantly more attentional failures at night compared to the 16-hour max schedule. Again, the question then becomes, does that really translate to clinical care? Is there a decrease in the quality of patient care if you do have these attentional failures, or are they clinically insignificant? So they did go further in this study to look at actual errors in the traditional schedule versus the 16-hour schedule. So if you look at the yellow bars, you'll see that there is, compared to the green bars, which is the 16-hour schedule, there is a significantly more medical errors and diagnostic errors from having that type of shift schedule. And that data was collected through surveys, through direct observation, reporting from the residents, and chart review. So that's how that data was collected. All right, so let's talk about another consequence of sleep deprivation, drowsy driving. So this is a very important topic. So aside from the actual personal safety, which we'll talk about in a little bit, there are potential legal implications for house staff driving without having enough sleep. So in New Jersey, it's considered reckless to drive without sleep for a consecutive 24-hour period. And there are laws in other states that are considered, that if you get into an accident or something that while you're drowsy, it's considered a felony. It's considered to be equivalent to driving drunk. So, and there have been, it's something to consider, and I don't know what the history is exactly in Tennessee, but there have been several high-profile cases where hospitals have been held responsible for staff driving tired and then having an accident. Right. So, signs of driving while drowsy. So if you have, this is stuff that you guys already know, but if you have trouble focusing on the road, if you have difficulty opening your eyes, nodding, yawning, drifting from your lane, not remembering that you drove yourself home, or micro naps at stoplights, that's a concern that you're driving while drowsy. Okay, so some strategies for avoiding this, right? So consider having a ride available at the end of your shift, or taking a taxi or an Uber to get home. Consider taking a nap before leaving the hospital. Pull off the road and take a nap if you feel like it's becoming unsafe. Those are sort of some of the strategies. Things like turning up the radio or chewing gum and stuff like that don't work. So. All right, the other, another potential impact of being sleep deprived in your training is impact on medical education. So that's like sort of what people think a lot about when we're decreasing duty hours, or are we decreasing residents' opportunity to learn from their interaction with patients? And the thought is that, after 12 or 13 hours, you're not really learning anything anyway. You're just trying to survive the rest of your shift. So that's sort of what some of these focus groups have talked about. So we go back to that survey study we were talking about that compared the amount of sleep reported by residents and their satisfaction with certain residency-related activities. So if we focus here on the red line, you'll see that as as the amount of sleep per night increased, the satisfaction with learning also improved. So recognizing sleepiness in yourself and others. So that's important, especially if you're making decisions on whether you should drive home or not, or whether you should be letting your intern drive home or not, etc. So another myth from residency. I can tell how tired I am and I know when I'm not functioning up to par. So this is a little bit like a lot of the drunk driving education, where do you really know how well you're functioning or not? So there was a study with anesthesia residents where they took a bunch of post-call anesthesia residents and they had them take a multiple sleep latency test. So that's a kind of a standard sleep test that is helpful in determining whether patients have narcolepsy or what other cause of sleepiness they might have. So that test is basically the patient spends like time in the sleep lab and they're given 4 or 5 opportunities throughout an 8-hour period to take a 20-minute nap. And they're hooked up to EEG monitoring, and basically what you're looking at is how fast people fall asleep, how long they're sleeping for during those 20-minute periods, and kind of they look at that to diagnose narcolepsy and sleep deprivation, things like that. So basically they had these anesthesia residents go through this test, and they found that a lot of their data from this sleep test was equivalent to patients with narcolepsy. The other kind of interesting thing that they found from this was that when they asked these anesthesia residents after they were observed for this whole day, taking naps and things like that, was how often do you think you fell asleep when you were here? And they greatly underestimated how much they actually fell asleep during that day. So really is not super accurate to just say, you know, I'm not that sleepy. And you can fall asleep briefly without knowing it, and that's called microsleeps. That's when you kind of go in and out, say, when you're going in and out of this lecture, that could be microsleeps. And so you don't know that you're doing it even. And that can be, you can see that can be dangerous when you're driving. All right, another residency myth. If I can just get through the night, I'm fine in the morning. So performance declines rapidly after 15 to 16 hours of continued wakefulness. And the thing about the morning, if, you know, that period of time between 6 a.m. and 11 a.m., which is the time when people are driving home from night float, say, is a period of lowest alertness. So something to consider when you're thinking about, should I take a nap before driving home from night float, etc., is that that's considered the period of lowest alertness after being up all night. So other warning signs for sleepiness. So falling asleep in conference or on rounds, feeling restless or irritable with your co-residents, with staff, with family. If you feel like you're having to check your work 2 or 3 times, if you have difficulty focusing on the care of your patients, or feeling like you don't care about the things that you normally used to care about. So part of the structure of residency, while things are sort of moving in a different direction, there are certain things that we can't really change right now in terms of hours, shift work, all of those things. There's to a certain degree can't be changed. But there are some strategies, but we will talk about a little bit about what's kind of in the works right now in terms of residency duty hours. But what can we do now in terms of management strategies for alertness? So napping strategies. So I'd rather just power through when I'm tired. Even when I nap, it just makes me feel worse. So I'm sure a lot of you guys have experienced that. You take a nap and then you wake up after that and you just feel like awful for a little while. So the thing is that getting some sleep is always better than no sleep. And the key is to keep your naps to 30 minutes, where you're not getting into a sleep phase that's a deep sleep phase. And that when you do that, that kind of causes sleep inertia, and that's that feeling of feeling awful after having a nap. So the key is to figure out what length of time that's short enough that you can take a nap where you'll feel better afterwards and not have that sleep inertia start. Okay? So kind of the ways to use napping. So one is preventative. So say you're on a night going to be having night float. Don't spend all day being awake. Try to nap if you can. So that's preventative. And then operational. So if you do have time during the day, take 20 to 30 minutes and try to take a nap, right? So don't take naps longer than 30 minutes. That way you avoid the sleep inertia. But something to note is that, if you are sleep deprived, you might slip into deep sleep even faster. That's called sleep latency in like sleep terms. But so that's something to keep in mind, that you might have to keep the nap a little bit shorter to kind of avoid getting into deep sleep. And then take advantage of circadian windows of opportunity. So 2 a.m. to 5 a.m. and 2 p.m. to 5 p.m. So 2 p.m. to 5 p.m. is a little difficult. That's like a busy time of the day in the hospital. But, 2 a.m. to 5 a.m., if you're getting done with some of your work around 4 a.m., take advantage to try to get some sleep at that time, because that's like when your circadian rhythm has the most drive for you to sleep. So take advantage of that. Okay, so recovery from sleep loss. So all I need is my usual 5 to 6 hours the night after call, and I'm fine. So recovery from on-call sleep loss generally takes at least 2 nights of extended sleep to restore baseline alertness. So, I used to have a lot of friends in residency who, after their call night, would just be up all day, just to get stuff done and whatever, and then sleep the night. And really, that doesn't really then give you any recovery sleep. So that will just continue to increase your sleep debt, and you'll get into that cycle of being chronically sleep deprived. So after a call, it's really suggested you take the time and sleep all day as much as you need to, and then sleep that night as well. So I know it's like tempting that you have like a day where you don't have to be in the hospital, but it really will contribute to chronic sleep loss. Okay, caffeine. I don't really need to tell you guys much about this. So I'm sure you guys all use this now, but it might reduce some sleep-related deficits. But obviously it has some issues. You develop tolerance for it. If you drink it too late, you might disrupt your sleep and the diuretic effects. So how can you sort of protect your sleep time when you do get to have sleep time, right? So these are a lot of things, and if you have patients who have sleep issues, this is a great way to start also counseling them about sleep hygiene. So is developing kind of healthy sleep habits when you do have the time to sleep at home. So try to go to bed and get up at the same time every day. And obviously in residency and training, I know schedules are all over the place. Sometimes that might be a little bit difficult, but the attempt is to try to have everything be a routine, including your pre-sleep routine. So having sort of relaxation techniques, like if you want to listen to music, you take a bath before you go to bed, read a book, etc. Have that be a routine every night. Protect your sleep time. So, make sure that like your family doesn't call you all the time when you're supposed to be sleeping, etc., and try to enlist them to help you with that. And if you know that you're going to have a night on call, try to get 7 to 9 hours before you have that sleep loss. The other thing that they don't mention in this slide that I do want to mention, and this kind of goes under sleeping environment, I guess, is you want to keep your bedroom cooler temperature, dark, and quiet. And when I talk about this, now some of this you can't really do as being physicians. It's hard to do turn off your phone completely, right? But the thought is to try to keep electronic devices outside of your bedroom. So watching television in bed, like scrolling through your iPad or phone right before bed is considered detrimental to the sleeping process. And so even if you can't personally do it, if you have patients who have sleep issues, that's a big, huge recommendation for good sleep hygiene, is to keep the electronic devices outside of the bedroom. It does hinder sleep. You can avoid going to bed hungry, and also don't eat heavy meals right before you're going to go to sleep. Try to avoid heavy exercise right before you're going to go to sleep, and alcohol. So even if you're not, the slide says, using alcohol to help you fall asleep, even if you're not using alcohol to help you fall asleep, which is not healthy in and of itself, alcohol use in general can disrupt your sleep later on. So oftentimes, like, you do okay with sleep onset, but it might cause you to have frequent awakenings throughout the night. So it's something to consider when you're on a tough rotation and you need your full night's sleep, to maybe forego that couple glasses of wine at dinner or something like that. All right, so how to survive night flow. Some of this is a little bit repetitive, but protect your sleep from your family, etc. When you're at home during the day and working at night, during the day is when everyone's out and about doing stuff. So you are more likely to kind of get woken up by phone calls and things like that. So it's something to just make sure that the people in your family and your close friends know that you're on night float, and during the day you're sleeping. You're not awake and doing stuff. Try to nap before work. Some people have difficulty sleeping during the day, especially the first couple days when you're on night float. And the recommendation is you can try to split your sleep into 2 4-hour periods. So plan on waking up, have a snack, do something, and then go back to sleep again. Try and break it up, and try not to sleep maybe 6-7 hours in a row, but break it up a little bit. When you have to be awake, try to have as much exposure to bright light. And then when you're going home and sleeping after a night shift, to have your bedroom be completely blocked from light. Okay. All right, so we'll talk a little bit about operational measures to reduce fatigue. So, these are all great strategies, et cetera, but the ultimate solution to all of this is having some sort of structural solution for residency duty hours and work hours. And so that's a very controversial topic, especially in the last 5 to 10 years, where the controversy has been, if we decrease duty hours, are we really increasing patient safety, or are we decreasing patient safety by having more handoffs? So there's been a lot of debate about that, and about the education component as well for residents that I mentioned before. And a lot of the criticism of the ACGME increasing the work hour restrictions is that there hasn't been any solid data that those restrictions actually make an impact on anything. So there are 2 studies, one that's finished in surgery called the FIRST study, and one that is, I think they're just analyzing data and stuff now, called iCompare out of Hopkins, that are looking at the residency work hours and comparing it to the old system to see whether or not it's really a good thing that we're doing, restricting resident duty hours. So I'll talk a little bit about that in a second. But the other thing that operational stuff that we can do is to support resident well-being. So one of those things is to monitor for depression and burnout, which is, those rates do increase when there's chronic sleep deprivation. And there's some studies that suggest that it can increase anywhere, and this is a wide range, but 4% to 30% over 1 year for resident depression. So that's something to consider, having some things, support in place if that were to happen, right? And monitoring tactics. And, there's a lot of there are survey studies that suggest that 3/4 of residents report burnout symptoms with increased workload and work hours. So there's been a lot more focus throughout residency programs, and I think is here as well for having sort of training and resiliency and how to preserve your well-being while you're training. And then duty hour restrictions. So I'll just talk a little bit about iCompare. A lot of the data that I've presented today has been really old stuff, so I thought I'd talk a little bit about something that's current. So after the ACGME got all this criticism for instating all these duty hour restrictions without any real evidence for whether they'd be better or not, decided to do randomized control trial to figure out whether it was okay or not to do these sort of interventions. So they took 63, this is Hopkins, is the primary site, but they took 63 internal medicine programs and randomized them to have, this is just interns who had just a strict ACGME schedule where their maximum shift time was 16 hours versus a flexible schedule, which meant that you could have an intern have 24 to 30 hour call, or 24 to 28 hour call. They still had the 80-hour work week restriction, so that was like the only thing that they were comparing. And basically, they did this for a year and then looked at the outcomes. For primary outcome was 30-day mortality as compared to the previous year as well, but 30-day mortality compared between the two groups and their previous year before this intervention. And then secondary outcomes, and you'll see here that sleepiness is one of them. So they've completed that trial, I believe, last year, and they're just kind of analyzing data and all that, so the actual study hasn't come out yet. But the rumors are that there's no difference. So, all right. So in summary, fatigue is an impairment like alcohol or drugs, and drowsiness and sleepiness can't be eliminated in residency, but there are certain strategies that I mentioned that you could use to make those things a little bit better. Try to recognize when you're sleepy or fatigued or where you're dealing with symptoms of chronic fatigue and ways that you can sort of remedy that. And then when sleepiness interferes with your performance, talk to your supervisors and program director about how you can change that for you, and an individualized approach for changing that. So does anyone have any questions? Anything? Okay, that's it. If you have anything, just you can come up and ask me as well.